This is Suzanne Foley, and welcome to week 4 of the evaluation and treatment of auditory processing disorders. For this week, we are going to continue discussing the last two types of auditory processing deficits that need to be evaluated and review electrophysiology testing that is available for auditory processing. So the next skill that we're going to be looking at is temporal processing. And if you remember, temporal processing is the difficulty with hearing prosodic changes in speech that indicate tense or emotion. And so they don't hear timing changes or pitch changes in speech. So different stresses in words are difficult to hear. It certainly can lead to some social interaction difficulties because if someone is being funny or sarcastic, that is difficult to hear in the tone of voice. And so they misinterpret the meaning behind certain information. The testing for temporal processing disorders has essentially two different types. There is temporal resolution and then temporal ordering or patterning. And typically during an evaluation, you will do one of each of those tests, and we'll go through those differences. We also want to continue looking at tests that use non-linguistic or non-language-based stimuli, such as words and sentences. And there are several tests in this category that include that type of stimuli. So if we look at the two different types of temporal processing, temporal ordering or patterning includes duration pattern and pitch pattern, which is also called frequency pattern. And these are very valid tests, have been around a long time, very well established. The norms for these two tests differ in age. So your duration pattern is at 9 years old or older, and your pitch pattern is for younger children. So if you are going to test a 7 or 8 year old, you would want to start with pitch pattern. And then if you have an older than 9, you could certainly do pitch pattern, but I usually start with duration pattern. And if they have difficulty, you go down to pitch pattern. One of the issues with this test is that in order to determine where the deficit in the brain is, you have to modify the response pattern. And we're going to go into that in a little more detail, where it's not just the verbal response, but you have to have them give you a nonverbal response. And we'll talk about that a little bit more. So the tests that are listed on this slide have the frequency pattern or duration pattern, and then the next two are gaps in noise and random gap detection. The last two tests that I mentioned are tests of temporal resolution that has to do with hearing the timing changes in speech, where frequency pattern or pitch pattern has more to do with the pitch changes. But both of those skills are important, and so we want to look at one test in each of those categories. So you might do a pitch pattern and a gaps in noise, or duration pattern and random gap detection, to make sure that we are evaluating both types of temporal processing skills. So when you talk about a temporal processing deficit in the auditory system, you're essentially talking about the right hemisphere's ability to hear timing changes in auditory information. If it is in the right hemisphere, it's the brain's ability to detect that. In order for the patient to let you know they can hear the pitch changes, they have to give a verbal response. And in order for the student to say the pattern of high, low, high, or short, long, short, the information about that timing change crosses the corpus callosum to the left hemisphere. So when the student gives a verbal response, you have to really flesh out with a nonverbal response where the deficit is. So in this table, what this is saying is that If the child cannot verbalize, say they have an abnormal pitch pattern when they say it, they cannot say high, low, high. What could be the problem is the right hemisphere's ability to detect that pitch change. It could also be the problem of the corpus callosum, of the information having to go across that to get to the left hemisphere. And it could also be a left hemisphere language problem in assigning the label to verbally respond. So typically you will always start with a verbal response. If the student cannot do a verbal response, if it's abnormal, then you have to have them give you a nonverbal response. And some options for nonverbal responses are humming the pattern. Also, you can have them point to an arrow that's high, low, or long, short, long. You can have them gesture by pointing up or down, or giving like musical hand signals of what's high and low, but they're not verbalizing. So if the verbal response is abnormal and you have them give a nonverbal response, you're essentially taking out the potential issue being in the corpus callosum or the left hemisphere. So if you have a student that cannot do either a verbal or a nonverbal response, then you know that the problem is in the right hemisphere and it's truly a temporal processing deficit. If they cannot do a verbal response, but they can do a nonverbal response, then that eliminates the right hemisphere as a deficit area. If they can give a nonverbal response, that means their right hemisphere can detect the timing or pitch change. The problem then is in the crossover to the corpus callosum or the left hemisphere. So you have to look at the different score or different ability with a nonverbal versus a verbal response. Certainly if you have a normal test score with verbal, and you do another test in that category and it's normal for verbal, you don't need to do a nonverbal response. The only time you would have to do that is if the verbal response test is abnormal. So that's a tricky issue because you don't want to say that a child has a temporal processing disorder based on an abnormal verbal response, because the deficit could be in 3 different areas. We need to isolate that right hemisphere. And the only way to do that is to take out the left hemisphere and the travel to that across the corpus callosum as a factor. One of the other issues to talk about with temporal processing is there's a lot of research that suggests that timing changes, temporal processing is an underlying issue with language development, receptive language difficulties, and also with music perception, which affects our rhyming ability, which also affects our reading development. So there are a lot of issues that can be affected by poor temporal processing in terms of reading skill development, language development, communication skills. And so it's an important piece of our auditory function is temporal processing. There is also a large body of research in temporal processing in regards to hearing aid technology, that it is well known that as we age, our auditory system slows down. And so that's why often when you have older hearing aid patients, you say, don't talk louder, talk slower, because they need that timing ability to slow down and to be able to hear the differences in between the words more than they need the volume. And so there is a lot of research in temporal processing, particularly for hearing aid technology, in ways you've seen that in your hearing aid programming, where you can change essentially the processing speed of the algorithm to slow down or go faster depending on the age of the patient. So then we're going to go to dichotic listening, which again, we talked about in the last few weeks in terms of 60% of the children diagnosed with an auditory processing deficit have dichotic listening difficulties. And what this is based on is normal development from 0 to 12 should be that the right ear processes stronger than the left, because the most direct route from the ear to the brain is diagonal. So when information comes in the right ear, it's going to go directly over to the left hemisphere. When information comes in the left ear, it's going to go over to the right hemisphere, and then it has to travel over the corpus callosum to get to the left hemisphere. So there's a longer pathway. And as we reevaluate students, we are going to watch, is that left ear improving? And they call it a right ear advantage, which is really a left ear weakness. So is that left ear improving or coming up with time, or is it staying still? If you tend to see a left ear weakness that does not improve with time, then you may be talking more of a neurologically based learning disability or something more of a damaged system versus a delayed system. And so that's one of the reasons why we want to reevaluate periodically to see if their left ear comes up in auditory processing. What happens with this, and the analogy I gave in the first few weeks, is that there are two skills, binaural integration and binaural separation. I'll get back to that. So binaural integration is the ability to take information in from both ears and understand it. So the analogy I gave was listening to someone talk on the right ear on the phone, and someone comes up to you on the left and you can hear and understand them. Conversely, binaural separation is directed listening. Can I listen to the person in the right ear and ignore the person on the left? Students with dichotic listening deficits or deficits in binaural integration or separation cannot do either. So the result of that is they are overwhelmed in background noise. Things are not clear, they can't understand, and they can't isolate or separate the information either. And so you will see difficulties with background noise. The other issue to think about is that if the basis behind this as far as brain function is that the myelin on the corpus callosum that connects the right and the left hemisphere is not fully developed. And so as the child improves, the consensus is that the myelin improves the development and neurons are able to fire across the corpus callosum more efficiently. So if auditory information is not crossing that corpus callosum, it's likely that you have other right-left activity that is not either. So some related issues with these kiddos is that they have difficulty with doing a verbal and a motor task. So a or left hemisphere with a right hemisphere task. So things like listening and taking notes, or looking and taking notes, where they have to use the left hemisphere language knowledge along with the motor task, is difficult for them. And so when we talk about the need to be deficit specific in our evaluation, it's because we want to be deficit specific in our interventions. A typical classroom accommodation for auditory processing is to look and listen, to use visual skills to maximize what's missed auditorily. And in these students, you don't want to recommend that. They need to do one or the other, not both. And so that's where you see a difference in deficit-specific recommendations versus general recommendations. So these tests typically are given with information that goes to both ears at the same time. And if it's an integrative task, they have to repeat both ears, the information from both ears. If it's a separation task, they ignore one ear and repeat what's in the other. And there are a variety of different stimuli there for tests. There is dichotic digits, which is a very commonly given test because it uses numbers. And we've said that numbers have a low linguistic load, meaning the left hemisphere does not light up, so it minimizes the language impact. You also have competing words. That is a test that has more language input into it. And then you also have dichotic sentence identification. That is binaural integration, and also the SSW, which is not on here. Let me see if that's the SSW is another very strong test for binaural integration. The two that are listed here, dichotic rhyme and dichotic CV, are not used clinically very commonly, but they are mentioned. And then the binaural separation is competing sentences, where they hear a sentence in each ear and have to ignore what's happening in the right or just repeat the left, and vice versa. And then again, the synthetic sentence identification test with CCM. We saw the SSI-ICM in the auditory closure where the stimulus and the competing message was in the same ear, the ipsilateral ear. In this, you have competing noise in the opposite ear. So they have to listen to the signal in one ear and ignore the competing noise in the other. So you're testing binaural separation in that task. So typically in this category, you're going to do one test of binaural integration and one test of binaural separation. If there's an abnormality, then we always usually go back and do another one of one of those skills. And you will see patterns emerge that rarely do you have binaural integration deficit without binaural separation deficit. They tend to go hand in hand. So you will have poor scores on these dichotic tests and then maybe normal scores on auditory closure and binaural interaction, possibly temporal processing, depending on where the deficit is. So again, normative data suggests that you will have a right ear advantage through age 12. So at age 12, the right and left ear should be at 90% in any response. Up to that point, the norms will have the left ear less than the right, and that's normal. So what you're looking for if you're testing an 8 or 9-year-old is their left ear where it should be, or is it lower than it should be, meaning there's a delay in that development. There's also, it can be consistent with when you have a significant left ear deficit with a language-based learning disability. So you certainly want to continue to watch that in terms of other appropriate recommendation. And then we go to the use of electrophysiology tests. And in our field of audiology, we often feel that electrophysiology tests are better than behavioral tests because there's no response needed, or they're more of an objective measure. Excuse me, but the concern is in terms of auditory processing, the tests that we use do require a state of alertness, and in some of the tests, an actual response. So they're not as objective as you would think. What we are looking for from electrophysiology tests in auditory processing is beyond the brainstem responses. Now, ABR testing can certainly be important in terms of a triage to rule out auditory neuropathy, which can often look like auditory processing. So, but not as a diagnostic tool. ABR is not used in auditory processing. It's more of a differential diagnosis. So in this slide of electrophysiology responses, you can see that we're talking about the ABR response initially, and then we're going to the middle latency response and then the late response. In between there is the MMN, the mismatch negativity, and the P300 response. So we're going up into the cortical area looking for abnormalities. Electrophysiology testing is certainly, in theory, good for nonverbal patients, for patients that may have significant articulation errors and can't verbally respond, children with syndromes or poor language, or any other condition where we're trying to look at the integrity of the auditory system. So one of the analogies I give, which is my own analogy, and it might not be relevant, is the difference between doing aided speech perception and functional gain versus real ear. That real ear is telling us is important to make sure that we are matching in that specific patient the target gain in the hearing aid. What real ear does not tell us is what the patient perceives as far as speech understanding, where we will get that if we do aided speech perception testing in the booth. Similarly, the electrophysiology testing in the evaluation of auditory processing may tell us what the brain function is doing, but it doesn't tell us how the patient perceives that information or how they're going to respond to that information. So realistically, if you're going to use electrophysiology, it's very important that you include behavioral testing in that as well. And the goal of electrophysiology is to validate behavioral tests or have the information match up. So the most common electrophysiology tests used would be the MLR, the late evoked, the P300, and the mismatch negativity. For years, we anticipated that the functional MRI would show a lot of promise because we could actually see areas of the brain that would be lighting up in response to certain stimuli. The challenge is the noise of the machines. If any of you have had an MRI, you know that they're very loud. So if you're trying to do any auditory stimuli, it's invalid because of the background noise of the machine. There are actually research projects going on in academics trying to get the noise level of MRI down so that we can evaluate actual brain activity to certain academic situations. And there are ways that they're working through that. In the week's information, there's a great table by Hall that goes through the different electrophysiology tests and the disadvantages and advantages. And that's really the most important piece that we want to know about auditory processing is what EP tests are available and what are the pros and cons of each of them. You also have to look at equipment issues and cost issues. That certainly something like the P300 is a module that can be added to an ABR. The MMN, which has the most promise because the MMN response can be recorded in infants. So we could actually detect at a very young age if there's an issue. The clinical application of MMN is not there. In fact, there's not really even valid norms at this point for the MMN. So research-wise, they're working on it, but clinically, as far as the ability to use it, it's not really there. The P300 is probably used the most that I have seen, and then the middle latency response is one as well. And usually it's done in universities or research centers, although the P300 was used quite a bit in VA research in terms of auditory processing with mild traumatic brain injured veterans. And they use the P300 as one of their protocol tests. So you'll see that one used. And again, it's because you can add that to an ABR module clinically. The other test that showed some promising use was a speech-evoked auditory brainstem response. That was called the BioMap, and it was developed out of Nina Krause's Northwestern lab, which Nina's lab does some amazing work in looking at pre- and post-intervention electrophysiology responses. So if looking at are there actual electrophysiology changes in the brain pre- and post certain interventions so that we can make better decisions about recommendations. And the BioMap had some great applications because it was looking at beyond a tone ABR, what happens when we give a speech signal or a word and mapping that response. And there were several people that bought it and used it and then found that it wasn't as helpful as they thought. There is another company that has purchased the rights to BioMap and are using it in research to try to develop more of a speech-based signal in electrophysiology, which certainly would help look at what the impact of speech perception is on the auditory processing scale. So we're watching that closely as well. So these slides discuss, again, each of the electrophysiology tests, where the response occurs, and what that test is used for most appropriately. It also discusses the abnormality for central auditory processing. So for example, the MLR here, it says that looking at the amplitude and latency of certain waves to see if it's abnormal. So is it delayed latency? What's the abnormality? The same thing for all of these. Again, the P300 they mention here, you have to attend to a stimuli. So it's not as objective as we think. There is a patient response or alertness that needs to be there. And again, for specifics, the P300 with a auditory processing deficit is going to have longer latency, smaller amplitudes. And it says here the P300 has been used in more research regarding pre and post intervention outcomes than any other because of the ease with clinical application to it. So the Hall summary in the literature talks about the advantages and disadvantages, the instrumentation needed, and the clinical application for that. The last category we want to talk about is electroacoustic, which is looking at things like reflexes and OAEs. There was a study by JIRSA that said that only 40% of audiologists doing APD were using OAE measurements. And the theory was that a lot of the evaluation for APD is being done in the educational setting, which may not have access to OAE test equipment as much as a clinical setting may in audiology. In clinical aspects, either hospital-based, private practice, universities, OAEs are typically done. And there's some reasons why. One, we want to make sure that we're evaluating that inner ear cochlea system in terms of triage for auditory neuropathy. We want to look at that to make sure that it's intact. And from my clinical perspective, what's been more interesting is that as I see teenage older students, I'm seeing normal pure tone results with abnormal high frequency OAEs. And so there's an opportunity to talk about noise exposure. Many of the students that I have seen with this situation have a significant history of noise exposure, whether it's farming, hunting and target shooting, or more often than not, high school marching band. And so I've been able to talk about preventative hearing loss and tinnitus, and talk about earplugs and musicians' plugs to try to reduce the impact of that. And then reflexes, often in my experience, especially in teaching over the years, there's a real 50-50 response on how many audiologists are using reflexes due to some of the inconsistencies, particularly with children and fluctuating middle ear fluid and negative pressure, that an abnormal or an absent auditory acoustic reflex may be due to that middle ear more than anything, similar to OAEs, and that both of those are affected by that. So you don't want to use acoustic reflexes diagnostically on their own, certainly in most situations, but particularly in children. But it is something to consider and look at, especially if you find an abnormal ABR. You're looking for patterns of neurological impact that may require further evaluation or referral. And so you want to look at all of those.